So, good morning, doctors. I am Cadag, a first year resident at St. Luke's Global City, and I will be discussing the pediatric chest part 3. So, this is the coverage of my report, and let me start with the chest wall. So, it involves anything above the thoracic inlet, and this is a list of the chest wall lesions in children. They are predisposed to acute respiratory distress even with partial obstruction due to the following. It is also important to note that a chest X-ray should be done in children with asymptomatic palpable anterior chest wall lesions, and no further evaluation is done if the X-ray is normal. So first is pectus excavatum. It is the most common congenital deformity of the sternum, and it is due to misdirected rapid growth of the lower costal cartilages. So this is an pectus excavatum in an 8-year-old girl. The lateral chest radiograph shows the sternal depression, shown by the arrow, causing narrowing of the AP diameter of the thorax. The atrial CT image shows severe anterior depression of the sternum that is compressing and displacing the heart. The Haller or pectus index is used to assess and describe the chest age on CT of the thorax. It is normal if it is less than 2.56 and corrective surgery is needed if it exceeds 3.25. And the Haller index for this patient is 4.7. So pectus carinatum is less common. It is an outward displacement of the sternum with secondary abnormal protrusion of the ribs. So this is a lateral chest radiograph, shows an increased AP diameter of the thoracic cavity and extended retrosternal space as shown in the arrow. So osteochondroma is the most common benign osseous neoplasm involving the chest wall. It most frequently from the ribs. It is usually diagnosed on plain radiographs in the first 3 decades of life and has a male predilection. It can be solitary or multiple. A chest radiograph shows this chest radiograph shows a large pedunculated osteochondroma shown by the straight arrow and seen arising from the undersurface of the right scapula. That causes remodeling of the underlying right ribs and chest wall deformity. The curved arrows show the smaller lesions in the left scapula and the 10th rib at the mid-axillary line, producing a focal rib deformity. So this is another image of osteochondroma in a 13-year-old male. Image A is a chest X-ray showing a high-density lesion at the left chest wall, as shown by the arrows. And image B and C is a CT scan showing a calcified lesion arising from the left ninth rib, with which protruded and puts pressure on the diaphragm, the stomach, and the spleen. So next is Ewing sarcoma, family of tumors, are the most common primary chest wall malignancy in children and young adults. And they often present with a rapidly growing, palpable chest wall mass that is often painful. So this is an HL contrast enhanced CT image of an 11-year-old boy who presented with a painful palpable lump in the anterior chest wall. It shows focal thickening of the anterior aspect of the right rib, as shown by the arrow, with surrounding soft tissue mass. Next is the diffuse lung diseases, or childhood interstitial lung disease, are made up of a diverse group of diseases without a predominant disease, which, unlike in adults, the most common primary cause of ILD is idiopathic pulmonary fibrosis, which does not occur in children. The CT appearance is frequently non-specific and often overlap, making it difficult to make a specific diagnosis. However, there are also several CT appearances that suggest a specific diagnosis. So this is an article by Catherine Owens and Maria Klassman. The article discussed the use of HRCT in helping to make the diagnosis in certain conditions, in guiding biopsy and allowing monitoring of disease progression with therapy. So in the article, they show the picture that shows a summary of the different HRCT features of the diffuse interstitial lung diseases. Certain more specific HRCT findings may be prominent with specific entities. However, HRCT findings are generally not pathognomonic and may represent a variety of histopathological processes. So this topic is a bit diverse, and it is better if we read it during the course of our residency. So next is the systemic conditions affecting the lung. Um, Primary immunodeficiencies can be classified by the affected component of the immune system, and and the chest radiograph presentations vary depending on the type of immunodeficiency present. For humoral or B cell immunodeficiencies, bacterial infections are more common, and for cellular T cell immunodeficiencies, viral or other opportunistic infections are more common. Newborn screening can be done to test for other primary immunodeficiencies such as severe combined immunodeficiency and Dieter's syndrome. However, there are no screening tests for the majority of primary immunodeficiencies, and diagnosis is usually made when there is frequent or unusual infections that occur. So a chest radiograph of these patients usually has a smaller absent thymus, adenoids, or tonsils, which are a feature of several primary immunodeficiencies and can be useful for differential diagnosis. However, it is not always definitive of an immunodeficiency. So one example is from this journal of pediatrics is this case of a 33-week-old male who presented with respiratory distress and fever after the birth of a mother experiencing an acute diarrheal illness. So this is a chest X-ray on the first day of life with a normal appearing thymus represented by the widened mediastinal shadow with well-demarcated borders. So this is the same patient on day 9 of life. Notice that there is absence of the normal widening of the mediastinum that suggests absence or decreased volume of the thymus. This can be seen in primary immunodeficiencies but can also be secondary to involution due to acute stress, which is what happened to this patient. So next is cystic fibrosis. It is caused by an autosomal recessive mutation in the cystic fibrosis transmembrane regulator, leading to ineffective mucus clearance. It is the most common genetic disorder leading to chronic pulmonary disease in children and is identified by newborn screening. These patients experience recurrent infections with extrapulmonary manifestations, and chest imaging in early cystic fibrosis may be normal and can show mild bronchiectasis and bronchial wall thickening with some mucus plugging. So this is a patient with cystic fibrosis showing middle lobe pneumonia, mucus plugging, and bronchiectasis. So as you can see, there's an opacification in the right middle and lower zones and abutting the horizontal fissure superiorly, while the right heart border is preserved. There are also minor tram tract densities in the left lower and right mid zones. And next is the rheumatoid or vascular disease. It is usually seen in teen years and present with diffuse lung disease, which is the most common pulmonary manifestation. A band-like or focal peripheral areas of reticular ground glass may precede diagnosis and may suggest this etiology. So this is a CT scan of a 17-year-old with polymyositis showing peripherally oriented reticular ground gas opacities. It is important to take note that idiopathic pulmonary fibrosis may present with a similar appearance, but idiopathic pulmonary fibrosis does not occur in children. Pulmonary hemorrhage may also occur in patients with collagen vascular disease, just like this CT image of a patient with collagen vascular disease who presented with hemoptysis. It shows diffuse and somewhat patchy ground glass opacification in both lungs, which suggests pulmonary hemorrhage. So next is lung trauma. So rib fractures occur as a result of blunt trauma, such as falls or motor vehicular accidents. Although in children, the ribs are more flexible than those of adults, and substantial lung injury can be seen without rib fractures. This frontal chest radiograph shows fractures of the 7 to 9 ribs posterolaterally and more subtle fractures of the left 10th and 11th ribs. A fracture is also pointed by the arrow seen through the neck and body of the left scapula. There is also subcutaneous emphysema seen along the lateral side of the left chest wall, as well as a fluffy consolidation in the left lower lobe consistent with a pulmonary contusion. Spontaneous pneumothorax occurs primarily in teenage boys and is classified into two types. Primary, which is more common and where there is no associated respiratory disease, and secondary pneumothorax occurs when there is a respiratory disease present. So this is a chest X-ray of a patient who presents with progressive chest pain and dyspnea. And there is a large pneumothorax on the left causing hypoexpansion and restrictive atelectasis, leading to lung collapse. And there is also minimal pleural effusion on the left. The next is pneumomediastinum. And, pneumomediastinum in children usually have no identifiable etiologies, or if an etiology is identified, asthma and foreign bodies are important causes, and esophagogram is not routinely required in children. So these are the signs of pneumomediastinum, particularly in the pediatric age group. The spinnaker sail sign or angel wing sign, pointed by the white arrow, refers to the thymus being outlined by air with each lobe displaced laterally and appearing like a spinnaker sails. So the haystack sign is pointed by the yellow arrow, where the heart is surrounded above and below with gas, giving it an appearance of a haystack from when it's spinning. Next is the upper airway. In evaluating the upper airway, it is similar to of the adults, and it is important to take note of the differences of the upper airway in adults versus in children. So the images obtained should be during inspiration and with an extended neck to avoid buckling and normal airway collapse. So these are the airway infections. So flu is also called laryngeal bronchitis and is common in 6 months to 3 years of age and is usually caused by parainfluenza virus. There is a reactive inflammatory response that leads to subglottic edema and upper airway narrowing. The signs and symptoms include gradual onset of low-grade fever, stridor, barking cough, and hoarseness. So, this, in the AP view shown in image A, there is symmetrical subglottic narrowing causing loss of the normal shoulders of the subglottic airway, called the steeple or pencil point sign. And on the lateral view, the subglottic airway blurs below the vocal cords, reflecting the narrowing seen on the frontal radiograph, on the frontal view. The epiglottis is normal as pointed by the asterisk. Its mildly broad appearance reflects a U-shape or omega epiglottis. More important to the shape of the epiglottis in distinguishing flu from epiglottitis is the appearance of the epiglottic folds, shown by the arrowhead, which should be thin. So, epiglottitis is inflammation involving the epiglottic folds as well as the epiglottis. Although due to Haemophilus influenza vaccine, this has become very rare. The presentation of epiglottitis is very rapid, starting from a sore throat and leading to difficulty swallowing and drooling, and it is a life-threatening infection. So this is an epiglottitis in a 5-year-old boy with respiratory distress and drooling, a lateral soft tissue neck radiograph showing a markedly thickened epiglottis shown by the white arrow, which is referred to as the thumb sign or thumbprint sign. The epiglottic folds, shown by the black arrow, are also thickened. So the thickening of the epiglottic folds differentiates it from flu. The next is retropharyngeal abscess. It is the spread of oropharyngeal flora to the retropharyngeal lymph nodes caused by group A streptococcus. It occurs before 5 years old and often in the first year of life. And when evaluating this retropharyngeal abscess, it is important to take note of the redundant soft tissue causing retropharyngeal soft tissue widening, as this can be easily mistaken for pathologic widening. So, as you can see, this is the normal width of the prevertebral soft tissue at the various cervical levels. So from C2 to C4, the prevertebral soft tissue should be only be one third of the vertebral body width, and C4 downwards should be one. The ratio is 1:1 width to the vertebral body. The lateral radiograph of of a retropharyngeal abscess demonstrates soft tissue swelling posterior to the pharynx with a widening of the prevertebral soft tissue. Next is laryngomalacia. It is the most common cause of noisy breathing in infants, where it results in stridor. It is the result of a congenital abnormality of the cartilage in the larynx that results in the dynamic partial supraglottic collapse of the larynx during breathing. So it presents in the first month of life and with improvement by 6 months. And almost 90% of cases spontaneously resolve. The diagnosis of laryngomalacia can be established with the use of airway fluoroscopy, although laryngoscopy is a diagnostic procedure of choice. So this is laryngomalacia in a 3-month-old boy with stridor. Image A is a still image from an airway fluoroscopic study demonstrating the normal position of the epiglottis, as shown by the arrow. And image B shows the laxity of the epiglottis with posterior downward movement obstructing the airway, consistent with laryngomalacia. Well, I think that is my last slide for the questions. What is the most common congenital deformity of the sternum causing narrowing of the diameter of the thorax? So it is pectus excavatum. So which of the following is an autosomal recessive mutation of in the CFTR that can show a normal or mild bronchiectasis in a plain radiograph? So the answer is cystic fibrosis. Which of the following presents with a steeple or pencil point sign? So the answer is two. So that these are my references, and that is all. Thank you, and have a good day.
Hello, Dr. Cadag. That was a excellent presentation. No, you covered a very comprehensive topic and was able to deliver the goods. So I just have a few things to add. No, whenever you're interpreting a chest X-ray, particularly in teenagers, well, even in neonates, don't forget to look at the chest wall because the chest wall, is neglected sometimes, particularly in teenagers. Do not neglect the chest wall. Pectus excavatum is one of those things that are not readily discussed all the time. But the reason why people get chest x-ray tapos may pectus excavatum, meron na silang underlying insecurities, no? The people with pectus excavatum, they hide their chest. Lalo na pag nag-teenager na sila during PE, etc. Or they go swimming, may mga insecurities yan. So this is something that we have to capture. So in some cases, it needs to be repaired. So don't forget the chest wall. Interstitial lung disease is a very difficult course, and it requires a lot of explanations. So I'm glad that you said, this is best being read. Don't worry, I will give you guys a talk on interstitial lung disease. Another thing about immunodeficiency, if you see repetitive pneumonia in a child, and then you see mga 3 years old and below, magtataka ka bakit walang thymus and then pabalik-balik yung kanyang pneumonia. Think about immunodeficiency state. So that's a good thing to keep in mind. No thymus, repetitive pneumonia, repetitive infections, maybe this patient has an underlying immunodeficiency. You talked about cystic fibrosis, this is something I see almost every day sa previous practice ko in North America. But having been in the Philippines for 17 years, I have not seen a confirmed case of cystic fibrosis. So this is very uncommon or even rare in the Filipino population. But once in a while, maybe sa mga expats makikita mo. Airway, uh, napaka-broad ng topic. I saw some cases na pinakita mo. They're all high yield yung mga pinakita mo today, no? Very very important to keep in mind. Even a chest X-ray and the lateral view, don't forget to look at the airway because sometimes they present with dyspnea, pneumonia, etc. Pero yung pala ang main problem nila is sa airway. So don't forget to look at the airway. So yun lang. Thank you so much. Good job.
Hindi pa, Doc.